Hello everyone, this is Dr. Upasana, and today I'm going to talk about the module Oncology, and today we are going to discuss a panoramic view of the gynecological cancers. So this is our part 2 MRCOG Kickstart series. Today is a struggle, tomorrow is hope. The future belongs to us who keep trying. So let us first look at the topics which you need to cover in the oncology module. The topics are ovarian cancer, cervical cancer screening, cervical cancer, endometrial cancer, vulval cancer, staging of all the gynae cancers is very important, as you may be asked both SBAs as well as EMQs from it. And these are usually considered easy questions which you shouldn't miss out on. Cancer survival statistics is another important part, and it can be asked both in the form of SBAs and EMQs. Cancer in pregnancy, how to manage the various forms of gynae cancers in pregnancy. That is again a very important topic. Usually you are asked about cervical cancer management in pregnancy. And last but not the least, regarding hereditary cancer risk, regarding BRCA syndrome, Lynch syndrome, etc. Now, after knowing regarding what are the topics to read, now you need to know where or what and where to read all these topics from. So first and foremost, the most important is the NHS cervical screening program. And from this, you can expect at least 2 EMQs, at least single set of PMQ that will be around 4 questions. So this is a must for the exam, and you can expect at least 2 to 3 SBS from this topic as well. FIGO cancer report, as for all the gynae cancers are concerned, is a must for you to cover in the oncology module. And some related TOG articles which you must cover is management of pregnancy after trachelectomy, pelvic exenteration, management of gynae cancers in pregnancy, review of gynae malignant melanomas, vulval intraepithelial neoplasia, Lynch syndrome, endometrial cancer and obesity, molecular and genetic basis of inherited cancer risk in gynae, borderline ovarian tumor, risk-reducing surgery for women with a high risk of epithelial ovarian cancer. Fallopian tube as origin of non-uterine pelvic high-grade serous carcinoma, surgical management of malignant bowel obstruction, update on chemotherapy in gynae cancer. So these are some of the TOG articles which you should go through the important points and the important tables, which are from where you are usually asked questions. And a few of the SIPs, one is on fallopian tube cancer, management of germ cell tumors. So all these things you need to cover from the SIP. So always remember, for part 2 MRCOG, which is the most difficult part out of the 3 series or 3 parts of MRCOG. So please practice as many SBAs and EMQs as possible. Try and cover the maximum number of SBAs and EMQs you practice, the more confident and the more likelihood is of success for the exam. So please try and practice regularly, follow a schedule, follow a course structure. Then it is all the more easier if you know where to read, what to read, and what are the topics which you should cover. So these are the most essential part, but otherwise part 2 is there is a vast syllabus to cover, and you should be knowing which are the important areas from where they will repeatedly ask you the questions. So again, we believe in the 3 R's, that is, you should read, you should revise, and then you should repeat. So this is what we mentors try and teach and try and make our students read, revise, and in the course structure, we try and tell you where are the important points and which are the important topics where you should read or you should highlight, so that you are able to do well in your exam. So now I'll just start with one by one cancer. So first we'll start from ovarian cancer. So first and foremost, you have to know regarding the staging of ovarian cancer. So I'll be dealing in this session, I'll be going through all the gynae cancers, and I'll be just covering the important points of staging and management, because most of the students come to us with a problem regarding how to manage this cancer and what should be the staging, and they still have doubts regarding the staging thing. So here in this short video, I'll be just going through the staging one by one, and we'll be also discussing some of the important SBAs and EMQs. So always remember, the first stage is localized disease. So if it is ovarian cancer, that means the first stage is confined to the ovaries or the fallopian tube. Accordingly, they have divided into 3 stages. 1A, where it is limited to one ovary or fallopian tube with no tumor on the ovarian surface or the fallopian tube surface, no malignant cells in ascites or peritoneal washings. 1B, just change 1 to 2. So that is 2. If both the ovaries are involved, then the same thing is 1B. Now coming to 1C. 1C is a very important thing, because this is what they keep asking you. They'll just give you a scenario and ask you regarding the staging. So 1C1 is if there is an iatrogenic spillage or there is a surgical spillage during the operation. 1C2, if you find capsule has already invaded the surface of the ovary or the capsule has ruptured before the surgery. 1C3 is in case you find malignant cells in the ascites or the peritoneal washings. Now coming to stage 2, stage 2 is when there is pelvic extension. That is, always remember, stage 1 is localized disease. Stage 2 is it just extends beyond the localized disease. So there is just an extension. So in case there is extension to the uterus, or in case it is an ovarian primary and there is extension to the fallopian tube, that also makes it 2A stage. And in case there is extension to other pelvic intraperitoneal tissues, then it is stage 2B. Now coming to stage 3. So stage 3 is always lymph nodal involvement is usually considered as stage 3. So stage 3A1 is in case the retroperitoneal lymph nodes are positive. So what do we mean by retroperitoneal lymph nodes? This is a very common question which is asked by the students repeatedly. So retroperitoneal lymph nodes involves both the pelvic as well as the para-aortic lymph nodes. So in case the size of the metastasis is up to 1 centimeter, then it is 3A11. And in case it is more than 1 centimeter, then it is 3A12. In case there is microscopic extrapelvic peritoneal involvement with or without positive retroperitoneal lymph nodes, then it is 3A2. And in case the peritoneal metastasis is up to 2 centimeter in greatest dimension, then it is 3B. So if it is microscopic peritoneal involvement, that is 3A2, and in case it is macroscopic but up to 2 centimeter, it is 3B. So what is 3C? So 3C is more than 2 centimeter. That means any peritoneal metastasis beyond the pelvis up to more than 2 centimeter in greatest dimension. So if the question mentions to you that the patient has a omental caking, what will be the staging? In case there is no other disease elsewhere or there is no other parenchymal metastasis, then the answer will be 3C. Omental caking is usually more than 2 centimeter, so it is usually a 3C disease. Now coming to stage 4. So always remember, any distant metastasis is stage 4. So this generalized view, if you know regarding the staging, the same thing applies for all the gynae cancer staging. Okay. So stage 4A is pleural effusion with a positive cytology, and 4B is any parenchymal metastasis or metastasis to extra abdominal organs like inguinal lymph nodes or your mediastinal lymph nodes or anything outside the abdominal cavity, that is stage 4B. So please remember that in case the tumor just extends to the capsule of the liver or the capsule of the spleen without any parenchymal involvement of any of the organ, then it still is staged as 3C. Only parenchymal involvement will upstage it to stage 4B. Okay. Now coming to some of the histological characteristics, these are important. They are usually asked in the form of SBS, that is in serous epithelial tumor. You have Samoma bodies, clear cell tumor, Hobnell cell, Brenner tumor, Walther cell rest, dysgerminoma, large polygonal cells with a lymphocytic infiltration and fibrous septa. Teratoma, you have all the three dermal structures, that is skin, hair, teeth, neural tissue, cartilage, thyroid tissue, endodermal sinus tumor, you have Schiller-Duval bodies, and in embryonal carcinoma, you have embroid bodies. Now coming to the management of ovarian cancer, how do we manage it? Mostly it is surgery followed by chemotherapy. That is, you can go for a surgical staging and followed by adjuvant chemotherapy, or you can go for something known as neoadjuvant chemotherapy, where you can go for surgery. First, you can go for chemotherapy 3 cycles, followed by interval debulking surgery, and then again followed by adjuvant chemotherapy. So in case you think that you will not be able to operate the ovarian cancer and you will not be able to achieve an optimal cytoreduction, that is, what do we mean by optimal cytoreduction? That is less than 1 centimeter of the residual tumor left behind in the body. If you think that you will not be able to achieve something known as optimal CRS, then we usually opt for neoadjuvant chemotherapy followed by surgery followed by adjuvant chemotherapy. So 3 cycles of NSCT followed by interval debulking surgery followed by 3 cycles of adjuvant chemotherapy. So in case of stage 1A, 1B, grade 1 and 2, there is no need of any adjuvant chemotherapy. Always remember that if it is grade 3 or a high grade tumor, then always you need to give them the adjuvant chemotherapy. Usually we give chemotherapy in the form of paclitaxel carboplatin for 3 to 6 cycles. And the most important prognostic factor in a case of advanced ovarian cancer is the volume of residual disease after surgical debulking. So that is, therein lies the importance of doing an optimal CRS. That is, you should not leave behind more than 1 centimeter of residual tumor in the abdomen of the patient. So in case the patient has an allergic reaction to paclitaxel or has an early sensory neuropathy, you can go for docetaxel, because docetaxel is less neurotoxic and is more myelosuppressive. So this is what we do in case of a staging surgery for epithelial ovarian cancer. You need to take the peritoneal washing from all the quadrants of the abdomen, careful inspection and palpation of all the peritoneal surfaces, and you need to take peritoneal biopsy from the undersurface of the diaphragm, from the pelvic tissues, from the bladder reflection cul-de-sac, right and left paracolic recesses, the pelvic side wall. So this is what is known as random peritoneal biopsy. Then we do an infracolic omentectomy. We do biopsy or resection of any adhesions and a selected lymphadenectomy of the pelvic and the para-aortic nodes, along with a total abdominal hysterectomy and a bilateral salpingo-oophorectomy. So this is all about the primary management of epithelial ovarian cancer. Now, we all know that ovarian cancer has a predisposition for recurring, that is recurrent epithelial ovarian cancer. So recurrent disease can be of 2 types. One is platinum sensitive. So now we need to know what is the definition of platinum sensitive. So platinum sensitive recurrent disease is defined as in case the disease returns back after an interval more than 6 months after the completion of chemotherapy. So because the disease has recurred back after 6 months of completion of platinum, usually we give platinum-based chemotherapy, that is carboplatin paclitaxel, you can go for a re-challenge. The management of platinum-sensitive recurrent ovarian cancer is a re-challenge with carboplatin and paclitaxel. However, in these cases, there is a chance of paclitaxel neurotoxicity. Then you may need to substitute paclitaxel with gemcitabine or liposomal doxorubicin. Now coming to the second type of recurrent ovarian cancer, that is the platinum resistant. So platinum resistant is in case it recurs within 6 months after completion of chemotherapy. And the third type is platinum refractory. That means it has not responded at all to platinum and it actually progresses within or during the 4 weeks after completion of chemotherapy. So that is platinum refractory. So here in these cases, the prognosis is not very good and the second line chemotherapy is less than 10% effective and there is no advantage of combination therapy. We usually go in such cases with a single agent, liposomal doxorubicin or etoposide or topotecan or gemcitabine. So these are the chemos where we go for chemotherapies. The name, they can ask you the names. So just remember the names. Now coming to germ cell tumors, the most common germ cell tumor is dysgerminoma. And in germ cell tumor, you need to remember what is the associated tumor marker, or which are the tumor marker which is elevated in the particular germ cell tumor. So in case of dysgerminoma, you have LDH elevated. In embryonal, you have HCG. In immature teratoma, both alpha fetoprotein as well as LDH may be elevated. And in choriocarcinoma, it is SCGA. Yolk sac tumor, it is alpha fetoprotein again. Sex cord stromal tumors, among the sex cord stromal tumors, thecoma, you can have increase in inhibin. In granulosa cell, there is increase in AMH and inhibin. In Sertoli Leydig cell tumors, these are usually, they usually secrete testosterone. Now coming to the management of these types of germ cell tumors. So in germ cell tumors, you should remember that we can always, because they have a predisposition and they usually occur in the pre-pubertal or in the pubertal age group. So in such cases, there is a need of fertility sparing surgeries. And we have seen that these tumors are highly radiosensitive as well as chemosensitive. So in such cases, we can go for surgery, which is known as fertility sparing surgery. That is, just remove the affected ovary and the tube, leave behind the uterus and the other side tube and ovary, then go for chemotherapy. And it is associated with a very good prognosis. So usually in germ cell tumors, we go for something known as fertility sparing surgery along with chemotherapy in case it is not early stage. It is not early stage. That is, in dysgerminoma, we go for chemotherapy starting from stage 2A to 4. However, in case of immature teratoma, we go for chemotherapy in cases of 1AG2. Starting from 1AG2, we go for chemotherapy in immature teratoma. In 1AG1, we can avoid chemotherapy and we can keep these patients on active surveillance. In case of yolk sac tumor, usually we give chemotherapy for all the stages. Now coming to sex cord stromal tumors. So sex cord stromal tumors also occurs during the pubertal age group and also in the postmenopausal age group. So here also we can go something known as fertility sparing surgery in cases of early stage. That is in case of 1A, when there is involvement of a single ovary, we can go for a fertility sparing surgery. However, in cases of advanced stages, we have to go for a full staging or a debulking surgery. Now coming to borderline ovarian tumor. So borderline ovarian tumor is ovarian tumor which has not invaded into the, which do not have any stromal invasion. So in such cases of borderline ovarian tumor also, we have to go for a staging surgery as we discussed an epithelial ovarian cancer. And usually in frozen section, which may be something which is reported as borderline ovarian tumor can be later classified as epithelial ovarian cancer in the final biopsy specimen. So you have to do a staging surgery. That is really important. However, in BOT, you should remember that we can go for a fertility sparing surgery because this also occurs in reproductive age group when in 30s and in their 30s and 40s when the patients desire for fertility. So here you can go for cystectomy and a unilateral salpingo-oophorectomy, preserving a part of the ovary so that the lady is able to conceive in the future. And in case the diagnosis is a borderline ovarian tumor, you did not go for any form of chemotherapy. No chemotherapy is recommended for management of borderline ovarian tumor. Now let us discuss EMQ on ovarian cancer. So just go through the options and try to answer along with me as I read out the questions. Try to frame the answer and then we will have a look at the answers. So for all of these cases, select the most likely diagnosis and each option may be used once or more than once or not at all. So first question is, a 45-year-old woman undergoes a total laparoscopic hysterectomy and a BSO for early endometrial cancer. She has a body mass index of 20, no relevant medical or family history, and at the time of surgery, her left ovary has a distinct yellow appearance. So distinct yellow appearance is suggestive of something, and that should give you a clue regarding the answer. Now, coming to the second question, we will be discussing the answers in a while. So, an 18-year-old woman with a pelvic mass arising from the right adnexa, lactate dehydrogenase is markedly elevated. So, here the clue points are always when you are answering any EMQ, try and note and highlight the keywords. So here the keywords or the takeaway thing is lactate dehydrogenase and the age of the patient, that is 18-year-old. So this is signifying that this is a germ cell tumor with the tumor marker of lactate dehydrogenase raised. So accordingly, you will get the answer, right? A 48-year-old woman undergoes TLH and BSO as a part of risk-reducing surgery for BRCA1 mutation. Histology of the ovary shows occult malignancy. So this is a RRSO for BRCA1. So what will be the malignancy associated? Now we'll have a look at the answers. So the first question was the yellow appearance, and she had endometrial cancer. So granulosa cell tumor is a estrogen secreting tumor, and they are associated with irregular bleeding and may have concomitant endometrial cancer. So that was the keyword for this. The keywords were in this question and the takeaway where you can actually derive the answer from. Now, lactate dehydrogenase, we all know it is dysgerminoma. In dysgerminoma, lactate dehydrogenase is markedly elevated. Now, coming to RRSO for BRCA1, then you found malignancies. So, in case of RRSO and BRCA mutations, the most common ovarian cancer which is associated is the high-grade serous epithelial ovarian cancer. So in case you notice which are the keywords, it is always easy for you to answer the question. Now we'll move ahead to endometrial cancer. That is the second cancer in the topic. So endometrial cancer earlier had a very easy staging in 2009. However, now in 2023, the staging was changed and it has underwent a lot of change, and in fact it is really hard to memorize this entire staging. But now they will be asking you questions from this revised and updated staging, so you need to remember that as well. Okay, so in case you go through the staging 2 or 3 times, you will be able to repeat them. However, I'll just try and make things simple for you. So stage 1 is something confined to the uterus or the ovary. That is what we have discussed. So stage 1A, they have divided every stage into 3 substages. That is 1A, B, C. So 1A is again divided into 3 types. That is 1A1. So that is non-aggressive histological type limited to an endometrial polyp or confined to the endometrium. 1A2 is non-aggressive involving less than half of the myometrium, and 1A3 is low-grade endometrioid carcinomas limited to the uterus and ovary. So earlier there was an entity known as synchronous endometrial and ovarian cancer that they have changed, and now they have included it under 1A3. Now, 1B is non-aggressive histological types with greater than 50% myometrial greater than 50% or 50%. Please remember greater than equal to, okay? It is always greater than equal to 50%. So in case they give you a question that 50% myometrial invasion, the answer should be 1B. Now coming to 1C, 1C is aggressive histological types limited to a polyp. So they have divided the entire histological types into 2 types. One is the aggressive variety, the other is the non-aggressive variety. Now coming to stage 2. In stage 2, there is again the same thing, that is cervical stromal invasion is 2A1. 2B is substantial LVSI and 2C is again aggressive. So remember 1C was also aggressive histological type. Similarly, 2C is again aggressive histological types with any myometrial involvement. Okay. So this is how you can easily remember the thing. Now coming to stage 3. Stage 3 is 3A is invasion of the uterine serosa or adnexa. So in case there is spread to the ovary or the fallopian tube, that is 3A1. Remember 1A3 and 3A1. So in case you just reverse it, so 1A3 becomes 3A1. So in case there is actually a spread to the ovary or the fallopian tube, it is 3A1. And in case it is synchronous, that is 1A3. We'll come to the criteria later on. Now coming to 3B, 3B1 is vagina and parametrial involvement, 3B2 is metastasis to the pelvic peritoneum. Again, I told you that 3C is lymph nodal metastasis. So any lymph nodal metastasis is 3C. Accordingly, they have divided depending on the size of the lymph node metastasis, whether it is micro or macro metastasis. Now coming to stage 4, stage 4A is invasion of the bladder or the bowel mucosa, 4B is abdominal peritoneal metastasis beyond the pelvis, and 4C is distant metastasis, that is metastasis to the extra or intra-abdominal lymph nodes above the renal vessels. So please remember peritoneal cytology. There are many students who have asked me this question, that does peritoneal cytology change the staging of endometrial cancer? No. Even in the revised staging in 2023, they have asked you that yes, you can collect the peritoneal cytology as while during the surgery as a part of the staging procedure, but however, it does not change the staging. Okay. Now, these are the important highlights or the important points which you should remember in the FIGO 2023 staging. That is, it is a surgically staged and pathological examined. And you need to remember which are the aggressive varieties. The aggressive varieties are high grade, endometrioid, endometrial cancer, serous carcinoma, clear cell carcinoma, mixed carcinoma, undifferentiated carcinoma, carcinosarcoma, mesonephric-like, GI mucinous type, and non-aggressive variety of endometrial cancer. LVSI, substantial or extensive, means involvement of more than equal to. Always remember, it is more than equal to 5 vessel. Macrometastasis is larger than 2 millimeter. Micrometastasis is 0.2 to 2 millimeter or more than 200 cells. Isolated tumor cells are up to 0.2 millimeter in size and up to less than equal to 200 cells. And another important thing in the FIGO 2023 classification or staging is regarding the importance of molecular classification. They have divided the entire endometrial cancer into 4 molecular varieties, that is polymutated, MMRD, NSMP, and P53 abnormal. So they have requested that in case it is available and feasible and the patient is able to afford it, please do a molecular staging in all the cases. Now coming to the criteria of 1A3, when you show how to differentiate 1A3 from 3A1 by the following criteria. So all these criteria must be fulfilled for you to stage it as 1A3. So what are the criteria? No more than superficial myometrial invasion should be present, absence of extensive or substantial LVSI, absence of additional metastasis, the ovarian tumor should be unilateral, limited to the ovary without capsule invasion or rupture. So I already mentioned you regarding the molecular classification. So remember, the good prognosis is with the polymutation, intermediate is with MMRD or NSMP, and P53 abnormal has the worst prognosis. Now coming to a quick SBA. So a 60-year-old woman underwent a TH-BSO and was diagnosed with a poorly differentiated endometrial cancer with more than 50% myometrial invasion. What is the most appropriate management? So I would like all my viewers here to please type me in the comment box what will be the staging of this cancer according to the revised FIGO 2023 staging. So it is a poorly differentiated endometrial cancer. For example, say it is grade 3 endometrial cancer with more than 50% myometrial invasion. What will be the FIGO 2023 staging? In case you are able to understand the staging, you will be able to answer it correctly in the comment box. However, we are discussing here what will be the most appropriate management. So here the answer is EBRT and brachytherapy. So because it is poorly differentiated with more than 50% myometrial invasion, you have to go for both EBRT and brachytherapy. So now let us look at the management, how to manage. So always in endometrial cancer, we go for a surgery followed by some form of adjuvant therapy if it is required. So in case it is 1A grade 1, usually hysterectomy BSO suffices in both grade 1 and 2. In case it is grade 3, that is a high grade variety, or 1B grade 1 or 2, only VBT is sufficient. However, here in this question, it was a case of 1B grade 3 with an aggressive histology. It was poorly differentiated. So you have to go adjuvant therapy in the form of EBRT as well as vaginal brachytherapy. So this is the answer to the question which we discussed. Now coming to stage 2, in stage 2 also you have to go for a lymphadenectomy as well as EBRT, VBT. Only lymphadenectomy you can omit in cases of stage 1A, grade 1 or grade 2. In stage 3, you have to give chemotherapy along with the EBRT and VBT. And in stage 4, you can go for debulking surgery, or you can go for chemotherapy followed by surgery, as in case of ovarian cancer, or you can go for a palliative treatment, palliative radiation, or hormonal therapy. Now coming to cervical cancer, we'll just look at the staging. So again, stage 1 is your confined strictly to the cervix. So 1A is when it is diagnosed only through microscopy. So 1A1 is less than 3 millimeter, 1A2 is less than 5 millimeter in depth. They no longer consider the horizontal extension, and they only consider the depth of stromal invasion. Now coming to 1B1. So 1B1 is less than 2 centimeter, the size of the tumor. 1B2 is less than 4 centimeter, and 1B3 is greater than equal to 4 centimeter. Remember, always greater than equal to 4 centimeter. Now coming to 2A. 2A is it is involvement of the upper 2/3 of the vagina. If it is less than 4 centimeter, it is 2A1. 2A2 is more than equal to 4 centimeter. 2B is with parametrial involvement. Now coming to 3A. In 3A, it involves the lower third of the vagina. In 3B, there is extension to the pelvic wall or the hydronephrosis, or in case it mentions non-functioning kidney, unless it is known for some other cause. In 3B, again in 3C, I have always told you it is lymph nodal involvement. So 3C1 is pelvic lymph node, 3C2 is para-aortic lymph node. 4A is always spread to the adjacent organs, that is bowel or bladder mucosa, and in 4B, it is spread to distant organs like liver, lung, bone. So always remember that this has to be a biopsy proven. Spread to adjacent pelvic organs, that is bladder or bowel, has to be biopsy proven, and a simple bullous edema does not allot it. A bullous edema is something which we see on a cystoscopy. It does not permit a case to be allocated to stage 4. Now coming to the management of cervical cancer in each of the stages. So in stage 1A1, you can do only a simple hysterectomy or a type 1 type of a type A or type 1 extrafacial hysterectomy. In case the patient wants fertility sparing, you can do a trachelectomy or a conization procedure. In stage 1A2, you need to do modified radical hysterectomy with a bilateral pelvic lymph node dissection, or a type B type of a radical hysterectomy. This is extrafacial is type A, modified radical is type B. And in case she wants fertility sparing, you can go for a radical trachelectomy. In stage 1B1, you can go for radical hysterectomy and BPLND, that is the type C type of a radical hysterectomy, or you can go for radical trachelectomy in case of fertility sparing, in case the size is less than 2 centimeter. In case of stage 1B, 1B3 actually, in case it is more than equal to 4 centimeter, that is in stage 1B3 onwards, you have to go for concurrent chemo radiation. However, in stage 1B2, that is, it is less than 4 centimeter, or in stage 2A1, that is less than 4 centimeter, you can go for a type C radical hysterectomy plus a BPLND. So in case the tumor size is more than 4 centimeter, or there is parametrial extension, that is anything stage 1B3 or stage 2A2 and beyond, you have to go for treatment in the form of concurrent chemo radiation. Okay, usually we give concurrent chemo radiation along with cisplatin. And in case the patient is renally compromised and you cannot give cisplatin, you have to go for carboplatin in those cases. Now coming to a question on cervical cancer. So this is a question regarding management of pregnancy in cervical cancer. So a 35-year-old woman is found to be 32 weeks pregnant when she is diagnosed with stage 1B1 cervical cancer. What will be the most appropriate treatment? So she is 32 weeks pregnant and diagnosed with stage 1B1 cervical cancer. So here you can actually wait and do a classical cesarean section followed by surgery. So already she is 32 weeks. So give her a dose of steroids and try to deliver her with a classical cesarean section followed by a radical hysterectomy. Because it is stage B1, you can go for a radical hysterectomy in the same setting with the cesarean section. Okay, so just to remember, this is the flow chart from the TOG article regarding how to manage cervical cancer in pregnancy. So just if I may tell you in brief, So in case it is very, in case the weeks of gestation, the period of gestation is more than 22 weeks and the woman is really desirous of fertility, then in such cases, you can delay the treatment till delivery, or you can go for neoadjuvant chemotherapy. However, if you detect the cancer at a very early gestation, that is less than 22 weeks, in such cases, you should advise the patient to go for either termination of pregnancy, or you can go for a lymph node. You can do a laparoscopic lymphadenectomy, that is pelvic lymphadenectomy. In case the lymph nodes are positive, that means it is a high stage disease. It will be again stage 3C1. In case pelvic lymph nodes are positive, then you have to ask the patient to go for termination. In case the pelvic lymph nodes are negative, then you can actually go for a simple trachelectomy, or you can delay the treatment till the delivery. So this is in brief regarding the entire management of cervical cancer in pregnancy. Now we'll go to the last cancer, that is the vulval cancer. So vulval cancer, similarly in the FIGO staging, was revised in 2021. This is the only FIGO staging based on the prospective data. So stage 1 is tumor confined to the vulva. 1A1 is less than equal to 2 centimeter and less than equal to 1 millimeter. Remember, this is the only where you have less than equal to. Everywhere it was more than equal to. So this is the only staging where it is less than equal to. Remember that. So 1A1 is less than equal to 2 centimeter, less than equal to 1 millimeter. 1B is more than 2 centimeter, more than 1 millimeter stromal invasion. 2 is in case it is involves the lower 1/3 of the urethra, vagina, or the anus with negative nodes. 3 is if involves the upper 2/3 of the urethra, vagina, and the rectum. That is, I remember it with the mnemonic UVA, that is urethra, vagina, and anus. And 3B is again regional lymph nodes. That is, here in case of vulval cancer, the regional lymph nodes are inguinal lymph nodes. Remember, in other gynae cancer, the regional lymph nodes were the pelvic lymph nodes. In vulval cancer, it is different. In vulval cancer, the regional lymph nodes are the inguinal lymph nodes. So 3B is regional lymph node metastasis more than 5 millimeter. 3C is regional lymph node metastasis along with an extracapsular spread. So 4A is in case it is fixed to the pelvic bone or fixed or ulcerated regional lymph node metastasis, and 4B is in case of distant metastasis. So remember here, your distant metastasis, in case it involves the pelvic lymph nodes, it also accounts as your distant metastasis, because the regional lymph nodes only refers to the inguinal and the femoral lymph nodes. Okay. Now, coming to carcinoma vulva, you have to remember that usually we go for a surgery that is in the form of MRV or a radical wide local excision. So the tumor-free margin should be 8 millimeter in the histopathology and 2 centimeter in the surgical margin. And the deep margin is usually the inferior fascia of the urogenital diaphragm. The distal 1 centimeter of the urethra can be removed without causing any urinary incontinence, and both the deep as well as the superficial inguinal nodes should be removed. And the definition of lateralized lesion is in case it is more than equal to 2 centimeter from the midline. Now coming to the management of carcinoma vulva. So 1A, you need to do only radical wide local excision, because here the risk of groin node metastasis is less than 1%. So no need to go and do a inguinal nodal dissection. In 1B, you have to do radical wide local excision along with lymph node dissection. So if it is a midline lesion, you have to go for a bilateral lymph node dissection. However, if it is a lateral lesion that is more than equal to 2 centimeter from the midline, you need to do a ipsilateral lymph node dissection only. In stage 2 to 4A, you have to go for CTRT followed by radical surgery with bilateral lymph node dissection. And in 4B, you can go for chemotherapy or concurrent chemoradiation with a local regional treatment along with a palliative intent. So now we'll quickly look at the SBA. So in the management of invasive vulval cancer, inguinofemoral lymphadenectomy can be avoided in all except. So in all these cases, you can let go of inguinofemoral lymphadenectomy, except the answer is D, because we have discussed that in case of squamous cell carcinoma with a depth invasion more than 1 millimeter, you have to, that is in case of stage 1B, you have to go for lymphadenectomy. Lymphadenectomy is not required in 1A, less than 1 millimeter, because of a very less chance of groin metastasis, less than 1%. Even remember that in varicose carcinoma, basal cell carcinoma, and in melanoma with clinically uninvolved nodes, there is no need for inguinofemoral lymphadenectomy. Okay, and now this is again another question regarding cervical cancer. So this is a 32-year-old nulliparous woman diagnosed with a cancer lesion at the anterior lip of the cervix with stromal invasion of 8 millimeter. There is no parametrial invasion, neither is there any lesion elsewhere. Cystoscopy and sigmoidoscopy are normal, and she asks for fertility sparing treatment. So what will you do here? So this is a case of fertility sparing treatment in cervical cancer. So you should go for radical trachelectomy and a pelvic lymph nodal dissection, because this is a case of 1B1 and she wants fertility sparing treatment. So in case you go back to the flowchart which I showed you, so the answer will be C, that is radical trachelectomy and a pelvic lymph node dissection. Now, this is an EMQ related to vulva. So let me just read out and you try and form the answers, and we will then discuss the answers. So the first question is, a 65-year-old woman presents with a history of vulvular discomfort and soreness for 6 months. On examination, 2.5 centimeter raised ulcerated area on the left labia majora, looks highly suspicious of vulval cancer. Biopsy is basal cell carcinoma. What will be the management? Number 2, 53-year-old postmenopausal woman presents to the GP with vulvar itching and soreness. Examination, 2.5 centimeter raised lesion on right labia majora, no palpable node in the groin. Ulcer is biopsied. Histology shows squamous cell carcinoma, stromal invasion of 2 millimeter. Role of sentinel lymph node is most established in vulval malignancy, and the sentinel lymph node biopsy came out to be positive in her case. So what will you do next? Now, number 3 question is, a 56-year-old postmenopausal presents to you with a history of vulval itching and soreness. On examination, vulva appears dry and scaly lesions throughout. On examination, she has a pigmented lesion on the right labia minora close to the fourchette. She has been receiving some treatment but with no benefit. So what should be her management? So now if we look at the answers, so the first one was a case of vulvar melanoma. So the management of vulval basal cell or varicose cancer or vulval melanoma, please remember it is a radical wide local excision with a 1 centimeter margin. And as I already mentioned, no lymph node dissection is needed here. Now, coming to the second question was regarding sentinel lymph node. You have done a sentinel lymph node in squamous cell carcinoma and it has come out to be positive. If in case the ipsilateral lymph node is positive, a sentinel lymph node is detected and it is positive, then you need to do a bilateral lymphadenectomy. Please remember this. And in case the sentinel lymph node is not detected, that is the ipsilateral, you have failed to detect it, then you need to do only ipsilateral lymphadenectomy. So please remember this. And already we know that in case of lateralized lesion, you can do ipsilateral only, and in case of median lesion, you always need to do bilateral lymphadenectomy. So the answer for the second question is radical wide local excision along with a bilateral inguinofemoral lymph node dissection in case the ipsilateral sentinel lymph node was positive for malignancy. Now coming to the third question, that is any change where she had some pigmented lesion. So any change in a vulval epithelium in a postmenopausal woman always needs biopsy because she has already taken medicines and she is not responding to that. So always you should take biopsy in the form of an incisional biopsy. Never ever in vulval cancer, wherever you are suspecting vulval cancer, you should do an excisional biopsy, because then the later part of staging the entire disease or the entire thing becomes difficult. Okay, so always in vulval cancer, it's always preferred to take a incisional biopsy. So let me know in case of any questions or any queries you have in this oncology module, and I'll be more than happy to answer all the questions. And again, I would like to tell you, okay, yes, I am Dr. Upasana. I am a gynae oncologist, and I would love to answer any of the questions. Do write in our comment box if you like the video, and please feel free to ask any questions in case you have any questions. thank you so much. Thank you so much for attending the video. And we are planning to come up with more series and more such Kickstart series so that we can spread knowledge and all of you are able to take this exam with flying colors. Okay, so thank you so much. Thank you. Bye-bye.